This podcast is Challenging Opinions and is presented by William Campbell.
Thank you for downloading the Challenging Opinions podcast for February 11th, 2019. We're back to healthcare. It's hard to get away from healthcare, but in this show I'm talking to someone who has years of experience advising and consulting on how it can and can't be reformed.
Challenging Opinions is the podcast where ideas are tested. Whether you are left or right, conservative or progressive, devout or skeptic. What matters is the strength of your argument, not the strength of your voice.
That's coming up in a minute, but first I want to say thanks to Ayomida Ologbenge and Christopher S. for signing up as patrons on Patreon since the last podcast. I really appreciate that, and if you can do the same, sign up to donate a couple of bucks per podcast or per month. I can promise you that'll go towards allowing us to put more work into researching and producing the podcast. I'll give details on how you can do that towards the end of the podcast. I was reading a piece called Unholy Alliance, Why Do Left-Wing Americans Support Right-Wing Muslims by Yasmin Mohammed. She's a former Muslim who, in her own words, ran away from the religious far-right world in which she was raised and made her way left towards values like gender equality, free speech and LGBT rights. And she continued, "Now, try to imagine the shock, betrayal and sadness I feel seeing fellow liberals celebrating right-wing conservative aspects of Islam. On February 1st, I was so upset over World Hijab Day that I spent the day in bed with a migraine. Hijab Day. Is there a Mormon underwear day? What about a chastity belt day? I risked my life and my daughter's life to escape from the darkness into the light, only to find the light celebrating and fetishizing darkness." That's what she said, and I think she has a point. I know that many Muslim women want to wear the hijab and do so without harassment, but for many others, it's a symbol of oppression and submission. And, let's be real here, for many women, it's a bit of both. Now, I can sympathize with the feeling that women who don't want to leave the hijab behind, or don't want to do that yet, they shouldn't be victimized. They shouldn't be treated badly on that basis, and them wearing the hijab shouldn't be used as a proxy, an excuse for racist or ethnic victimization. So, yes, defend the right of people to wear silly religious garb if they want to do that, and it doesn't restrict the rights of others. But there's a whole world of difference between that and saying that wearing the hijab is a good thing, that it should be encouraged and celebrated. Sure, some women in the West wear the hijab because they were brought up with it and they wouldn't be comfortable going out without it, and to an extent that's their choice. But we shouldn't lose sight of the fact that the hijab springs from a virginity hysteria in the deeply misogynistic culture that it comes from. Yasmin Mohammed is right that it is absolutely absurd for American liberals to be supporting it, or any other of the Bronze Age traditions that make up Sharia law. But they aren't the only ones being hypocritical. Let's look at many of the people who are setting themselves up, who are the loudest about keeping the evil influence of Islam out of the West. The Breitbarts and the Tommy Robinsons, the Nathan Demigos and the Black Pigeon Speaks, and all the alt and not so alt-right. Why do they want to do that? To preserve Western values, that's why. To defend the Enlightenment. The only problem with that is that the people who are so anxious to keep out Muslims for the sake of Western values and the Enlightenment are the same people who care least about Western values and the Enlightenment. Between them, they've attacked everything from due process and the rule of law to religious freedom, universal suffrage and democracy, and every individual liberty that has made the Western world what it is. There's an awful lot of hypocrisy out there. I can understand Yasmin Mohammed being disappointed with otherwise liberals doing the apologetics for the equivalent of the Westboro Baptist Church. And I hate having to make the choice. But when I do have to make the choice between silly liberals being too tolerant of a totalitarian religion on one hand, and on the other hand, knuckleheads with keyboards dressing up their racism as concern for something that I'm actually concerned about, I hate having to make that choice, but I think I'd tip the balance in favor of people believing in freedom and getting it wrong sometimes, rather than people believing in totalitarianism and getting it wrong sometimes.
Do you agree? Do you disagree? If you want your point of view heard, email podcast@challengingopinions.com and say what you think.
On the line now, I have David Introcaso. He's a healthcare policy consultant based in Washington, D.C. He's worked for the House Majority Leader, Steny Hoyer, when he was the House Majority Leader, and at the Department of Health and Human Services. And he's consulted for the American Heart Association, the American Public Health Association, and the United Health Group. And he's also taught as an adjunct professor at the University of Chicago and George Washington University. David, the issue of Medicare for all has come storming onto the political scene. What do you think of it?
Sure, thank you. Good question. The reasons why proponents are arguing is because our system has failed in numerous ways, least of which is there a significant percent or a number of Americans who have no health care insurance right now. That's about 30 million, so that's 30 million of those under the age of 65 or who are not eligible for the current Medicare program. So the idea would be this is by way of having universal health care. It would be single payer. The government would pay providers, and they would likely be for-profit private companies. So we wouldn't lose the private sector. Probably saw Senator Harris, who announced her presidential campaign, said, in some ways implied, although evidently she didn't mean it specifically, that would get rid of commercial insurance, so I think that's unlikely. But the idea would be if we had Medicare for all, everyone would be covered, and because we'd have one payer, it would be more spending efficient because right now we spend a substantial percent of the Medicare dollar on administrative costs, which were largely wasteful, and they are as high as they are because we have so many different providers. It's very administratively burdensome, and we know the Medicare and Medicare programs as they're run are extremely more efficient, spending efficient from an administrative perspective.
Is this really a quick and dirty way of moving the U.S. healthcare system into something that approximates to, that has some sort of semblance to the Western European system where you pretty much have state-provided healthcare available to everybody?
Absolutely. In fact, we're the only highly developed, industrialized country in the world that does not have universal coverage. So it's hard to believe or fathom how it is that every other highly developed, say, OECD country can do this, and we're unable. It's beyond understanding or explanation. Now, of course, how we do it matters, and that's where likely, if we get down the road, where the fight's really going to be had, exactly how we do it.
Okay. In the UK, they probably have the most socialized system in the sense that pretty much all hospitals are owned by the state. Doctors, nurses, all the various staff are state employees. The NHS, the National Health Service, is one of the biggest employers in the world. It has about 1 million employees. But as I see what people are talking about Medicare for all is they're sort of saying that the government would pay, but they would contract out the provision of services. So you wouldn't really have, doctors being state employed. They would be still employed by private entities, and hospitals would be private entities. Are you sure that you would get rid of all those extra costs that Americans are paying for healthcare if you still had all those private companies in the system?
Well, they would have to become more efficient because, again, there be no variation in reimbursement. So right now, of course, Medicare pays through, say, DRGs, prospective payment to hospitals. Hospitals are able to negotiate with commercial or private payers, 200-300% of Medicare.
Mm-hmm.
So you get great variation in spending or the amounts reimbursed. That would all go away. So if a commercial plan wanted to contract with the federal government and be paid, they'd all get paid the same. They in turn would hire, their network of clinicians. You'd see more uniformity in their salaries. As a result.
But pause on that for a minute, David, because clearly the theory here is fairly reasonable that if you've got a big purchaser, they have more purchasing power and they can negotiate a better deal with the supplier. But that doesn't always happen in reality with the government because, for example, you have, military spending, which seems to be almost the model for this Medicare for All, that the government pays huge amounts of money in order for private companies to supply, in one case, military hardcare, in the other case, healthcare. There's no real evidence that the government gets very good value for money when they're buying military hardware. In fact, there's a lot of evidence that they don't. Are you sure that the government have the skill set to use that negotiating power?
Well, first, let me back up on the NHS. So there is a fair amount of private commercial participants in UK healthcare. So, for example, Spire hospitals. But that aside, part of you make a good point as it relates to analogizing to the military, and each industry has its own uniquenesses. The military, of course, certainly a high barrier to entry, right? I mean, not everyone can build a F-35 or whatever up to in fighter jet technology. So there's not a lot of competition. Not too many firms can build these extremely high-tech military weapons.
Mm-hmm.
Less the case in healthcare. So I would think it is a legitimate concern or worry, but I would say they're not exactly on the same comparative playing field, the defense industry and healthcare provisioning. Now, maybe in some extent, when you get into very limited subspecialties where there aren't very many clinicians with that training, but we're talking primary care, nursing care, other types of care provisioning. I think there'd be a good deal of participants in competition.
Okay. One podcast that I did about a year ago, I talked to a libertarian economist called Yaron Brook, and he was very much against government-controlled healthcare. And he was brave enough to go in front of a British audience and say that they should abolish the NHS. I don't think he was received terribly well. But one figure that I found when I was researching that was that clearly the people in the UK pay through their taxes for the NHS. So you can say it's free. It's free at the point of use, but clearly it costs money. And people like Yaron Brook will say, well, yeah, you're going to pay a lot more taxes if you want this. In fact, the people in the US pay a larger percentage of their taxes towards government-provided healthcare, notwithstanding all the private insurance they pay more just in their taxes than people in the UK do. That's a startling figure, and it indicates that really people in the US are being charged way, way more for the same thing than other people in the West. Are you sure that you can get those costs out of the system?
Well, a couple things. First of all, we're at about $3 trillion plus, or $3.5 trillion annually, 18% of the GDP in healthcare expenditures. The reason I make
actually,
note
if I can just clarify that, the US pays about 18% in total of its GDP in healthcare. of which about half is, or slightly under half, is through taxation. In the UK, where very, very few people have private insurance, they just use the NHS, they pay about 7.5% of their GDP in taxes. That's to say less in taxes, even despite the fact that they pay almost nothing in insurance. Most people would not have private insurance. So it's an enormous difference.
Well, it is, and it's easily explained in that in the U.S., again, we're at 18%, trillions of dollars, about a third of that. So think of it this way. Americans are forced to pay every year $1 trillion for health care that does not improve their health. Okay? It's waste. And what explains that? The system is overbuilt. It's overcapitalized. We have too many hospitals. And why do we have too many hospitals? Because it's easy to make a profit. Second issue, compared to the UK and the rest of Europe, although it's a bit different for primary care docs, but our physicians or clinicians, and this is not popular to say, but compared to like countries, our physicians, particularly specialists, are paid much higher than their colleagues overseas. Now, of course, the immediate response to that is they pay more in liability insurance, although if you take that variable out, they're still paid substantially more. Again,
it kind of goes against the accepted wisdom that the private sector is much more efficient than the government sector. Is there any particular reason why that maxim, which is usually true, but it doesn't seem to be true in healthcare? Do you know why that is?
Profit. Look at.
Yeah, but if I was selling lawnmowers or any other product, I want to make a profit as well. Why is it that in the private sector does so badly at delivering value for money? If I want to get a hamburger, I can get it for very, very cheap, and I can have a great choice and so forth.
Right. That's the difference. You can evaluate. The consumer can generally, or all consumers can generally evaluate the quality or value of a hamburger. This goes back to Ken Arrow's infamous December 1963 essay about asymmetrical information and why healthcare is different. The average consumer in this country has no idea the value of healthcare.
When you say asymmetrical information, how can you translate that into English for the listeners?
Sure. Well, that's the phrase he used, so thank you for that. So basically what he said, it's asymmetrical information, which is the physician has all the information, the patient has little or no information. So you go to buy a car, there's a lot of data online, you can make a reasonably informed purchasing decision. When you go to a hospital and you need a certain surgical procedure, it's very complicated, you didn't go to medical school, you can't comparison shop because, again, although we're now requiring hospitals to post their charges, we'll see how successful that is. But the bottom line is consumers cannot, they don't have the ability to, and you use the magic word value, they're unable to determine or ascertain what provider gives or could provide them the highest value. Outcomes achieved relative to spending is the definition of value. If you try to calculate that in healthcare in this country, good luck. It's almost impossible. I, for years, have argued in letter writing, in comments in response to proposed rule for the Medicare program, that it needs to start. Now, it's not easy, but it needs to start measuring for value. And again, the classic definition, outcomes achieved relative to spending.
Sure. So essentially, how much money does it cost you to save one person with X type of cancer or whatever compared to some other country? But there are so many types of cancer and so many variables that it becomes impossible to measure that reliably.
Well, it can, but let's just talk about high-cost, high-volume procedures in the classic in Medicare, hips and knees. We do a massive amount of hip and knee replacement surgeries in this country. Why? Well, because they're very profitable, and many of them, absent fracture, are what are called preference-sensitive conditions, meaning you go in to see a surgical orthopedist, and he says, they're having too much pain with that hip. Let me change it. You'll be up and playing tennis again.
Mm-hmm.
It's a subjective decision. Those surgeries are, again, very profitable, but it's very difficult, if not impossible, for you. And keep in mind how many surgeons do these procedures. It's a vast number. You'd be hard-pressed to figure out which one produces the best outcomes.
So you can work out, because money is countable. You can work out who does it cheapest, but it's very difficult to work out who does it best.
Well, it's the ratio. I mean, should I pay $20,000 for the same pain I had before, or is it worth me to pay $30,000 for, relative to, say, patient-reported outcome measures for substantially less pain, say 90 days post-surgery?
I'm losing the will to live already. I don't think I could even understand that much information.
Well, the other issue is, think about it this way. How can you make a decision, these complicated purchasing decisions, when you're lying on a gurney? And keep in mind also, most people who need serious medical care are seniors, right?
Mm-hmm.
Aged people tend to be less healthy. A third of Medicare beneficiaries are cognitively impaired.
Mm-hmm.
So what's their capacity to figure this out? Little or none.
And the one other issue that strikes me as very relevant here, that nobody's talking about, whether they're on the more free market side or on the more socializing the cost side, is that, and as one economist put it to me a while back, said that if the price of a good goes down, the price of the resource that yields those goods goes up and down accordingly. And I said I didn't understand that. And he said that if the price of gold goes up, the price of a gold mine goes up. There are gold mines operating in the US, which are essentially medical schools who charge, and people coming out of those schools are typically hundreds of thousands of dollars in debt. Mm-hmm. And that's money that is filtered through various pockets, but essentially comes out of the healthcare, health insurance, and out of the various state payments of the Medicare and Medicaid. The bottom line is that a lot of people, if healthcare costs are to be reduced, a lot of people are going to have to be told, sorry, your nice little earner isn't going to be earning you very much money anymore.
The industry, the profession, the guild, whatever you want to call it,
mm-hmm.
It's in their vested interest, obviously, to limit the supply
mm-hmm.
of clinicians. It's basic economics. Not only that, in this country, we're unique in that physicians, clinicians, nurses, whomever, can practice anywhere they can receive a license. So we have a disproportionate number practicing in urban versus rural, and the old Econ 101 supply-driven demand. Not surprisingly, you have vast spending in Florida
mm-hmm.
because you have a vast supply of clinicians who all, of course, want to bill.
Mm-hmm.
But the bottom line is you want to get as large a risk pool as you can,
mm-hmm.
and that's one of the other advantages. If you had every American in one risk pool, in theory, and from that perspective, you'd have as most efficient from a statistical perspective and a per capita spending perspective as you can, because you would equalize the pain. Everyone would bear their share. And going back to the NHS, you probably know, of course, how did the National Health Service get created? It was after World War II.
Mm-hmm.
And everybody realized, well, look what we just did together. Right, we survived. 40,000 people died in the London bombings.
Yes, and there was a sense of community that drove
community,
that.
Right, and so with that thinking, they said we, as a group, it's a group activity. We prize individualism, but that doesn't work when you're talking about insurance products.
Okay, if I might just try and repeat that in English, and you can tell me if I'm getting this right. The
Sure.
bigger the risk pool, so if you have health insurance, essentially that one insurance company, or more likely they might divide it down into subcategories of groups of insured people. If you're in a pool with a whole load of old and sick people, then the cost of that pool is going to go high. If you do something like the individual mandate, you pull in lots of younger and healthier people who are paying premiums, but not really making very many claims because they're still quite healthy. That brings down the average cost for everyone. And if you make everybody, the whole nation, into one pool, then that averages that out across lifetimes, and it's also more efficient in terms of administration. Am I getting that right?
Right, and I'll just add to this. The reason why you want young people who say, I shouldn't have to pay, or there's community rating and I'm paying too much, whatever, this is one of those issues where we all succeed together or we all fail together. And the reality is, the way it works, and this is just a fact of life, you pay insurance when you're younger, and you're not getting any value, back to value, because you're healthy, you're not consuming, you're not filing claims, right? You're the young invincible. But the equation flips when you get north of 50, because now younger people are really floating your consumption or paying for it. And it's the same idea with Social Security. And that is why the idea of, if we don't get Medicare for all, we get a Medicare buy-in, which is to say, if you're less than 65, you buy into the program, you pay cost, but you buy into the Medicare program, and it's good for the Medicare program because they get people younger than 65 who, generally speaking, statistically, are healthier. And again, you want as many healthy people in the pool as you can to offset the utilization of the smaller percentage who are less healthy.
Okay. We've gone through a lot of questions that are really quite technical about healthcare, but I know that you've worked on the Hill in Washington, and you were a consultant for Steny Hoyer, as I mentioned at the start. So leaving aside the economics, leaving aside the healthcare issues, and looking just at the politics, do you think that there's a snowball's chance in hell of any of this happening even after 2020? Well,
I think there's more of a chance, obviously, after the next election. We're at this, we're pushing 20% of the GDP. I mean, the pain in what it costs to manage a healthcare system that is really largely failing from any perspective you want to look at it or measure. So, it's that old line that people change when the pain is calculated to be greater than, you consume an item if the benefit exceeds the pain in paying for it, right? So I think we'll come around to the conclusion that the benefit offsets whatever political, ideological pain or however it violates a person's political ideology. And again, there's so many variables. Beyond that, just the financing. If you look at, say, the IOM report of 13, I think it was 2013, Shorter Lives, Poor Health, Americans are at any age level, in horrible health, generally speaking. And for us to be successful in the long term, we can't continue to have as unhealthy a population. It just cannot persist.
David Introcaso, healthcare policy consultant and also adjunct professor at University of Chicago and George Washington University. Thank you very much for talking to me.
Thank you, William. I appreciate it.
Make your view heard. Email podcast@challengingopinions.com to set out your ideas and defend them on the next podcast.
Go to the website for sources and links to what we were talking about. And while we're there, please like the show on Facebook, follow @ChallengingO on Twitter, and follow David Introcaso @HealthcareIssue. And get in touch with me if you can suggest a guest or topic for a future show. And as I said, thanks to Iamida and Christopher and everyone else who has signed up as patrons on Patreon so far. I really appreciate that. It means I can devote more time to research and finding interesting guests. And if you could do the same as them and donate $1 or $2 per podcast or per month, you'll find the link on the website. Also, you can find out how to subscribe to the podcast for free on your computer, by phone or by email. It's all at www.challengingopinions.com. Coming up next Monday, that's February 18th, I'll be talking to Adam de Colibus, author of the novel Caravan. The Challenging Opinions podcast is produced and presented by me, William Campbell. The assistant producer is Nick Albertson. Thank you for listening.